Hi, folks. Thank you very much for having me here. My talk is going to be very much in the weeds, just trying to talk about one practical solution to the practical problem for consumers of choosing a good health plan. And uh, I want to show you a model health plan comparison tool that exchanges can adopt, copy, or take pieces of. Affordable Care Act says exchanges will assist consumers in making easy insurance choices. We want those choices not only to be easy, but to be the right choices, to be the best choices for people. And we want it to be easy for consumers with very little knowledge of insurance or the healthcare system without requiring a whole lot of time or education, because we know very well that if you take a lot of time or education, people just make a choice, whether it be on brand name or whatever. The basis for our recommendations is our nonprofit organizations' decades of experience producing websites and publications rating all kinds of services, from doctors and hospitals to auto insurers. None of our websites or publications carries any advertising. They're supported by consumers who pay to access the information, which of course is good discipline to try to produce something that people value and find useful. Most relevant here is our research and our user feedback, as we have for the past 34 years produced Checkbook's Guide to Health Plans for Federal Employees. There are certain features that we consider really key features in a good health plan comparison tool. A single dollar amount actuarial estimate of average total cost, premium plus out-of-pocket cost, for people like the user, same age, family size, health status, and possibly other characteristics. The user's range of risk with each plan, the total cost in very bad years, very good years, and the probability of having such years. An all-plan provider directory that lets the user immediately see for each plan whether it has doctors the user says the user wants, without having to go to each plan's provider directory one at a time. And a summary rating of each plan's care and service quality, but still allowing the user the opportunity to drill down and personalize based on the things that matter most to that user, if the user has the energy and capability of doing that. So I want to really focus on the cost comparison front. That's the thing that consumers tell us again and again they are most interested in. And I want to talk about some of the existing cost comparison systems that are out there in the world, and for people who have a choice. Many people don't even have a health plan choice, but if you do, what's out there to help people along with that. But the basic context is most people who are given a choice do it with what we describe as a benefit description model, which just tells the consumer the deductibles, the co-pays, the out-of-pocket limits, et cetera. But consumers can't figure out, is a plan with a $200 deductible and a $10,000 out-of-pocket limit better than a plan with a much higher deductible, a $1,000 deductible, and a $4,000 much lower out-of-pocket limit? What about different co-pays, co-insurance levels, et cetera? As Lynn Quincy has shown, and shown again today, but I've certainly read it numerous times in the past. Her work showing that many consumers don't know the meaning of co-payment versus co-insurance. Many can't even do percentages. These are the kinds of literacy problems that you're talking about today in very elegant ways, I think. But even in this field, even mathematicians who are expert in health policy can't make these kinds of comparisons using that kind of information. They won't know the likelihood of needing different types of health services or what the fees for those services are. So in an effort to simplify, people come up with different solutions. Good that they're trying to simplify out of that morass, but one of the solutions we see out there is what we call a known usage model that compares plans by asking how many doctor visits, prescriptions, et cetera, you expect next year, and then estimates the cost of all those services for you. And that's your dollar amount figure, which is better than at least having to wade through all of these benefit descriptions. May require a little effort to put all that information in, but that's not too bad if we don't lose the user in the process. But the really important problem with that kind of simplification is that it badly misleads by totally ignoring the very expensive heart attack, auto accident, et cetera, that you don't expect. And that's a major reason for having insurance. So that's the problem with that approach. Another simplifying solution is the one that is relied on by the UX 2014 model that was funded by a number of foundations. And what they do, or part of what they do, is they ask screening questions up front to early filter the list of plans down. So is a deductible of more than $400 acceptable for you? If not, that won't be on the list you ever see. Will you consider an HMO? No? Okay, it's off. Now we got it simpler still. Do you have a certain doctor? Do you have to have a certain doctor in the plan? Oh, okay, well, the doctor's on that plan. We don't have to show you those either. So we have simplified something. And if that were the only objective, that would be a great thing. Just maybe the wrong answer for you. Because the problem is that consumers, when they're doing this, don't know what they're giving up with those filters. That a plan with a higher deductible or an HMO or one with different doctors may be thousands of dollars cheaper next year and may have excellent providers and great service, but you don't know that. You've wiped it out. You never even see it. In fact, I would say in terms of consumer literacy that it wouldn't be a bad idea if we had time to sort of give people a little bit of literacy about not filtering up front. Because otherwise consumers make false assumptions like a low deductible is the best way to save money. I'll just take only plans with low deductibles. Or a low premium is a sure way to save money. Well, sometimes yes, sometimes no. So another way to simplify is plan standardization, and there's some real merit in that approach, where plans are maybe there are only 5 or 6 or 10 different benefit design models, so or benefit packages, and at least within that package, all the plans that are within that package are comparable in terms of out-of-pocket costs. So then all you have to do is look at premiums. The problem is that it really is important to compare across those packages too, because particularly for an older person who's sick, a younger person who's very healthy, whatever, they're a package that may be good for one person may be a very bad choice for somebody else. You need to look across those packages. So it is a simplification. We have a lot of illustrations in the Massachusetts Connector and elsewhere where you just wouldn't want to rely on that. And you really want to look across packages. Also, the more you limit the packages, it sort of reduces flexibility to the extent that that's useful in the healthcare system in terms of coming up with benefit designs that are particularly appealing to particular people. So the solution that we recommend, what we've been using for 34 years, calculates, as I say, for each plan, a single dollar amount actuarial estimate of average out-of-pocket costs for people like the user, same ages, family composition, health status, possibly other characteristics like planned expensive procedures. Our model and the model we would recommend uses data from the Medical Expenditure Panel survey and from other sources to estimate the likelihood of various types and levels of usage, charges for such usage for a family like the user. This is a single dollar amount combined with premium. It's easy for the user to compare. It doesn't require much literacy at all, or much numeracy at all. It's just dollar amounts, not too hard. In addition to average costs, in our tool, we at least like to offer people the option of seeing what the cost would be in a very good or a very bad year, and the probabilities of having such years. This actuarial approach, in recent years, the Medicare Plan Finder has picked up on that same approach. I'm going to just talk for a second about quality comparison. Then I want to actually give you a little tour through this model that we think is at least an illustration of how it should be done. So on the quality comparison front, very complicated to avoid literacy and numeracy skills in really comparing quality. You'll see in what I'm going to show you here that we do it in a very simplistic way. But you know, there are many challenges there. But one is to start with that many consumers don't attribute between plan differences in measures of quality of care, especially HEDIS type measures of quality of care. They don't attribute those to plans. They attribute them to the providers that the particular people chose within the plan or to the member's own behavior. So if we want to get patients involved in engaged in thinking about plan quality, we're going to have to educate them on that front, that yes, plans can have an effect if we believe they can have an effect. And then, you know, and these are just illustrations of other challenges. Plan-to-plan differences in quality are larger for some measures than for other measures. You'll see in what I'm going to show you here that we use 5 stars, right? So and we divide them into quintiles. Well, that doesn't give any sense of scale. You know, we were talking about scale earlier being very important. That doesn't give you a sense of scale. You know, that might be a big difference, but it still puts you in the top 5th. But as soon as you try to get beyond that, then you're getting into a level of complexity where people have to understand measures, have to understand math, et cetera. And so you have to make a trade-off here. You know, do you want to weigh them down in that, lose them in that, or do you want to just sort of give them something that's half okay? Another example is that we give them a summary measure, but we also want them to be able to drill down. But if you drill them down too early or force them all to drill down, you lose them again. Okay. So anyway, that's some context for all this. I do want to show you my if I can escape from this. I think I can. Oh, yes, I can. I did. Okay. Yes, I did. Okay. So I'm going to give you a little tour of what we would recommend as a way to solve this problem. What this is I'm going to show you actual information for real health plans that were in the Federal Employees Health Benefits Program. It was on a real live website for millions of employees if they wanted to use it last year. Although we've now we sort of tweaked it and adjusted it some so that this kind of model would fit in a health insurance exchange. So one of the things we've learned is that people like to get information, like to get explanations in different ways. It used to be it was all text, on our website, and there were reasons for that because computers were slow and so on. But now we do have a lot of video and audio things that we do, which people do find helpful and are much more accustomed to seeing. So I'm going
to your health plan comparison tool. Choosing the right insurance plan can be difficult and confusing. This tool is designed to answer the question, which are the best plans for someone like me, regardless of your knowledge of insurance? Tell us a little about yourself, and in just a few minutes, we'll find the best plans for someone like you, rank them by lowest expected cost, and report on plan quality, benefits, participating doctors, and more. Just click the blue Continue button to begin.
So I'm going to click that button. Oh, and this actually offers you to have an audio tour throughout. So as you went through, we keep telling you what to do and what these things mean. I'm going to give you that audio tour. But the next step, the person does have to build a family for us. Now, actually, the person really won't have to in an exchange because we'll already have this information. I'm going to make a family of 4, but we would already know that right out of the eligibility engine. So we don't even have to do that. But I'm going to put in some ages here if I can manipulate the keyboard here adequately. A couple of adults, a couple of kids. And then we asked them about self-reported health status because the Medicare Expenditure Panel survey asks people about their self-reported health status. And we know that it's a very good predictor of usage. We just asked them the very same question the Medical Expenditure Panel survey asked them. And so I'm going to put in some health statuses. So that, has a, helps in our doing this modeling. Then the other thing is they can choose procedures that they know they're going to have next year. There are a lot of procedures you don't know, but there's some you would know. So if it's a childbirth with vaginal delivery or whatever, you can make a pretty good guess you might be having that, or a hip replacement or something like that. I'm not going to choose any of those. I do have to put in a zip code to put this person in the place where the plans are. And then we proceed. The next thing is the person can put in the names of one or more doctors that the person would like to have available. I'll put in a couple of them. If they don't have a doctor, they can go off here and they can actually get some doctors who are recognized for quality or something to help them choose a doctor. We also give them a little warning here, or a big warning here. If doctor really matters to you, you better check and see if that doctor is really going to be in the plan next year. But anyway, after that, then we're off and we're actually at the results. You can see that the highlighted column here is estimated average yearly cost for families like yours. That's a combination of the yearly premium minus any tax subsidy or whatever, and the health care costs you may pay out of pocket. That combination is this yellow column here, which people can sort if they wish. And you can see it goes from almost 11,000 down to a little less than 3,000 for these particular plans that were available to federal employees last year. So that's a critical column, and it's most of what I was talking about in my preamble to this, is trying to simplify that cost, those numbers on the cost front. We also tell you the most you could pay in a year, that's, you can sort that again. You'll notice that if you sort it, there are a couple of staggering figures there. This mail handler's value plan, for instance, is at $28,000. I'll assure you that their plan brochure says our maximum is $8,000, something like that. But there are a lot of gaps in that. They don't happen to count prescription drugs in that against that maximum or whatever. So we adjust that so it's apples to apples comparison. But that's the second element, risk. Okay, so I'm going to resort just. And then we have a quality measure, and you can see this is the most simplistic thing. It's we have 5 stars, which we do actually is percentile, 5 quintiles that we've divided up these plans based on the overall CAP survey. But I'm going to take you back, if I have a moment, to show you how they're allowed to personalize. They can personalize and have different things that go into that overall quality score. But that's what the default is. And then you can see as your doctor in the plan. And in fact, you can click on that doctor and see, yeah, that really is the doctor. And you can also get this little bit of warning again that, hey, you better call and check. So those are the main elements here. About 60%, more than 60% of people make their choice based on this page alone. Well, you wouldn't want that to happen unless you thought the stuff on this page was the right stuff. But we actually do think, given what they've told us their interests are, that these are the things that really do matter, and you can simplify it down that much. There are other things they can do. They can, if one thing, if they don't understand things, we have more of these audio sorts of, things explaining, I don't know what.
Your costs for healthcare include more than just.
She's explaining what out-of-pocket cost is or whatever, right? You can also check a few plans to go side by side, et cetera, and then you'll see a side-by-side portrayal of these plans, okay? And that'll have a lot of detail. In fact, I should have shown you, there are all these other tabs here across the top, so you can see more cost information if you wanted to click on that, and it just depends how deeply people want to go. You can actually see what the cost in a low-cost year is, what the cost in a high-cost year, as I mentioned, what the probability of having those years is. But you can see, if you want to see that whole array of deductibles and co-payments and all that, hey, you can see it. Special coverage features is things like what do they do for infertility treatment and acupuncture and stuff like that. We have that. A lot of detail on dental if you want to see that. Plan flexibility. Do you need a referral to go to see a specialist? Things like that. Is an open formulary. a lot of stuff like that. I want to come back, though, to the key page here, and I want to show you one more thing about the personalization. So I clicked on that link to personalize, and then this gives us a lot of quality categories. So what members say about the quality of care, quality and availability of doctors and other providers, what members say about being able to get needed care quickly, and so on. And for each of those, you could click down to excruciating detail on this, or you could choose not to. But whatever you do, then you can decide how much weight you want to put on those things. So you know, maybe somebody says, well, I want to weigh what members say about quality of care a lot. I want to really care about quality and availability of doctors. You know, it's an insurance plan, so I care about customer service and claims handling. And maybe we've got diabetes or heart disease or something, you know, among my family members, so I really care about that. But if you're outside of childbearing years, you might pull these things and de-emphasize those. Then you submit, and you get a new score, or new for quality, or a new set of stars. And in fact, you'll see that that APWU plan, which had 5 stars, 3 stars before, now has 1 star. So you've redone that. The only other main thing I think to say about this is that at this point, we're more than happy to have you. Actually, I'm going to reset those so all the plans are available for the moment. But you can, if you want to eliminate the HMOs now, or you want to eliminate high deductible HDHP plans, that's fine. If you say, well, I've now really given my quality ratings and I really believe them, so I'm willing to say I want at least 3 stars, then you can submit. And now you're seeing a much more limited set of plans. But you now know what you gave up. And notice that, the lowest cost plan now is over $5,000. Before, the lowest cost plan was under $3,000. So you made that decision, but it wasn't that hard to get to that decision. We didn't have to do, it's not like they had to read through all those benefits to get there. The big thing is you can do a lot of stuff if you simplify that cost thing first. Then you can do a fair amount of stuff with quality and with, with these other types of decision making. So anyway, I think I've exhausted my time and probably exhausted you, so I'll stop. Thank you very much.